Welcome to Maternal Substance Abuse and Child Development. This is going to be a brief presentation on the effects of maternal substance abuse on child development. First, I want to acknowledge some of the sponsors of our work. This include the National Institute on Alcoholism and Alcohol Abuse, the National Institute on Drug Abuse, and the Georgia Department of Behavioral Health and Developmental Disabilities. I also want to state that I have no conflict of interest to report. One of the most important things we need to understand about substance abuse by women is that most of the time we'll be talking not about abuse of a single substance, but by polysubstance abuse. The majority of women who use alcohol and drugs during their pregnancy and during breastfeeding use more than one drug, though they may have a preference for one drug over another. And most common among all the drugs used during pregnancy and breastfeeding are cigarettes and alcohol. The next most common substance of abuse is marijuana and also prescription medications, which they may receive from their physician or may buy on the street. Cocaine and perhaps methamphetamines are probably the next most common, and opiates, about which there's a great deal of concern now, for good reason, is probably the next most common. We've heard also a great deal about synthetics like spice and other synthetic marijuana. These are relatively uncommon, although they do exist. Another important thing to understand about substance abuse by women is that usually these are women who are using these drugs, who become pregnant. They are likely to reduce their use during pregnancy. They're not likely to begin during pregnancy. And many of them, if they do quit during pregnancy, may resume use postpartum. Here is some data from SAMHSA, the National Survey on Drug Use and Health, which is collected by the federal government. And it discusses how frequently pregnant women use various drugs. And as you can see, as we mentioned earlier, the most commonly abused substances reported by women during pregnancy are tobacco and alcohol, followed by marijuana, illicit drugs of various sorts, and opiates. Note that there is a difference in different age groups of women, with those people who are between 18 and 25 more likely to use illicit drugs, marijuana and tobacco, and those women who are older more likely to use alcohol. This chart shows illicit drug use during the past year among women who are 12 years old and older. Again, you can see that the most commonly abused illicit drug, which is to say illegal drug, is marijuana. Psychotherapeutics are substances that are given as therapeutic agents for women who have emotional problems, and unfortunately those are frequently abused as well. Here we see that among illicit drugs, opiates are used frequently, and cocaine is also frequently used, particularly among younger women. Just to review, when we look at how much alcohol is used, a recent study from the Centers for Disease Control found that a great many more women are using alcohol in pregnancy than we generally believe. In fact, as many as 11.5% of pregnant women drank, and at least almost 4% of those reported binge drinking. Binge drinking is drinking 4 or more drinks at one time. Unfortunately, the rate among unmarried pregnant women was higher overall than the rate among women in general. And when we look at those who reported binge drinking, the average number of drinking occasions was 4 times per month, and the number of drinks at a time was 6 drinks. So you're looking here about a substantial amount of alcohol use. We may ask what the consequences of this are. And a recent study, which was done in 2018 by Phil May, Tina Chambers, and a number of colleagues, looked at the prevalence of fetal alcohol spectrum disorders, or those conditions caused by using alcohol in pregnancy, in 4 different communities in the United States. This is the first study that examined this issue in a systematic manner. This was done in first-grade classrooms in children in the Midwest, in the South, and in the Southeast. In the Southwest, I beg your pardon. They identified a much higher rate of FASD than had previously been believed to occur. Previously, the idea was that it was about 1 per 1,000 who had FAS, and that maybe 2 or 1 per 100 may have had FASD. As it turns out, the prevalence rate is closer to between 1 to 5% of those who are identified in first-grade classrooms having some kind of FASD. When we look at smoking, we find that there's a high prevalence of smoking before pregnancy, during pregnancy, and after delivery. This was also, this data is from 2013, but it hasn't changed dramatically. There is we believe that there is a decrease in smoking overall in the population of the United States. Nevertheless, there remains a reasonably large number of women who are smoking. As you see in this particular group, from 2000 to 2010, about between 20 and 25% of women were smoking. About between 10 and 15% were smoking during pregnancy, and 15 to 20% were smoking during breastfeeding or after pregnancy. Another interesting point is the areas in which smoking is most likely to occur. And as you can see, this is not the same across all states. The darker the state is on the map, the more likely there was to be smoking during pregnancy. And it looks here like West Virginia is the top ranked state for smoking during pregnancy. Prescription drug abuse, as I mentioned, is a very common use during pregnancy. And many individuals in the United States use prescription drugs for non-medical reasons, which is to say to get high or for other reasons, sometime during the year. Women, because they're more likely to go to a doctor, and also because they're more likely to complain about pain for either physiological or social reasons, are much more likely to be prescribed a drug and are twice as likely to become addicted to it. Let's talk about some of the drugs that are prescribed, prescription and other drugs. Many of the opiates that are being abused and used in the United States now are prescribed. Some of them, like heroin, are not, that are illegal substances which are sold illicitly. But some of the opiates that are being used are in fact prescribed. And most of these natural and synthetic drugs that fall into this category have similar characteristics and effects. And you see here a list of them. You have opiate, morphine and heroin, methadone, codeine, buprenorphine, hydrocodone, OxyContin, and finally fentanyl, which is, these things are sort of working up from the most basic to the most, those drugs which have the highest effect. Opiate use leads to an increase in the number of receptors associated with opiate exposure and the number of receptors that react to it. Sometimes this causes an increased number of receptors, and this leads to the development of what's called tolerance, eventually dependence on the drug, and in some cases addiction. If someone wishes to quit using these drugs, it can be very unpleasant, and this leads to a phenomenon called withdrawal syndrome or abstinence. There has been an increase in opiate abuse in Georgia in the last period of time, although like many areas, because now we are aware that this is such a problem, there is probably a slight decrease in the number of drugs prescribed. The areas in which you see heroin-involved overdosing are shown on the map. And again, you see this is most commonly occurring around big cities. In this case, clustered around Atlanta, but also you see more of it around Savannah. This graph shows the number of prescriptions or number of metric tons of amphetamine, methylphenidate, and other stimulant medications, which are reported to the Drug Enforcement Administration from 2006 to 2016. These are stimulant medications. They have a very different effect from the opiate medications. They produce a high, and they are all manufactured all over the world, but certainly within the United States. And you can see that there are a great many drugs being produced that have this kind of effect. And not surprisingly, there are therefore a number of drugs being prescribed and used. What happens when the pregnant woman uses these drugs during pregnancy? What is the effect on the woman and the child? Well, we begin with the idea that the woman who is pregnant is part of a family, and that her use is going to have an effect within the family and on her own life that may have a negative impact on the child. As I had mentioned before, substance use by women is often polydrug use. Women who are drug abusers are frequently themselves abused, and within the families in which this kind of abuse is occurring, children are often at risk for neglect and for abuse themselves. Women who are substance using are frequently alienated from family and friends. They become isolated, and they often have few social resources to turn to when they need help. Such women also often fail to access existing resources that might be helpful to them and their children. This may lead to what is called medical neglect. That is, they may not take their child for medical care when needed. It can also be associated with school problems and failure to use social services that are available. People who are substance abusers often have problems with work. This may interfere with them being able to carry out their work in a reliable manner. Many people who are substance abusers lose their jobs or find themselves in very peripheral employment. This leads, of course, to problems with financial issues within the family. Substance abuse is frequently associated with mental health problems as well. And we often think of depression as what's called comorbid with substance abuse problems, so that substance abusing women are frequently depressed. They often are anxious. They often are diagnosed with mental health issues. Many of these things that we've mentioned can lead to legal difficulties. Individuals who are abusing substances are frequently having to resort to illicit activities in order to gain the money that is necessary to support the habit. They may have problems with operating a vehicle and get in trouble with DUIs of various sorts. They may get in trouble in terms of caring for their children leading to problems with dependency courts, so that they will be taken into court because their children are being neglected. As you might imagine, these kinds of family issues can have very negative effects for children. Children of drug abusers have a much higher risk for placement outside the home. They are more likely to enter foster care system, and they're more likely to remain longer in foster care than children who come into care for other reasons. Children of drug abusers have higher rates of school absenteeism, and unfortunately, they're almost 3 times more likely to be abused and more than 4 times as likely to be neglected as other children. In addition to these social problems, there are a number of effects related to the exposure to the drug itself. To summarize very briefly, when we're talking about alcohol, there are global cognitive effects. The child may have a lower IQ, they may have intellectual deficits, they may have specific neurodevelopmental problems, learning disabilities. Academic problems are common. For children of cocaine users who are exposed to the drug during pregnancy, there are frequently arousal regulation problems, and some groups have identified problems with executive function, which is planning, organization, and also problems with emotional development. When we examine the effects of smoking and/or nicotine, tobacco use on the child, we see problems with auditory perception, which is the ability to perceive and evaluate the sounds that you're hearing. We see problems possibly related to auditory perception in early development of language. And then there's regular reports of problems with conduct and behavior among children who were exposed to tobacco prenatally. When we look at the effects of opiates, one well-known outcome that is regularly observed is neonatal abstinence syndrome, which I'll describe more later. There may be other effects as well, and these things are being researched at this time. When we look at marijuana, which has become an increasing concern over the last years due to changes in the laws all around the country related to marijuana, there is evidence among some studies of mild cognitive differences that it can be observed later on in development, particularly in later childhood and during adolescence. Let's talk more about marijuana. After alcohol and tobacco, as I mentioned, marijuana is the most commonly used drug in pregnancy. There have been no physical birth defects found to be associated with marijuana in any way that's reliable. Growth retardation is not common and is not persistent. And there are no clinically significant effects in the newborn period. There have, however, been studies that have looked at the long-term effects of marijuana exposure on development. And there are 2 very well-known and well-carried-out studies that have examined clinical effects of prenatal marijuana exposure. One was done in Ottawa by Peter Freed and his colleagues, and another was done in Pittsburgh by Nancy Day and her colleagues. Both of these studies were done some years ago, and both have followed individuals from birth up until early adulthood. There are some questions about whether or not these studies, which were done many years ago, are useful in understanding what is going on currently as relates to marijuana, since there may be changes in the nature of the marijuana that is being distributed. In the findings from the Ottawa study, there was no impact of prenatal marijuana on overall ability, which is to say IQ. And he found no impact on basic visual spatial skills. However, deficits were noted in higher order complex skills involved in problem-solving tasks that required visual integration and analytic skills. There were also problems noted in those in sustained attention, the ability to continue to pay attention and to focus one's attention. These skills are also what is referred to as executive functioning skills. Freud called this a top-down impact, and this implies that this is the result of effects to the prefrontal cortex, those regions of the brain that control planning and organizational skills. When we look at the Pittsburgh study, which was done at about the same time, we find that this particular study carried out comprehensive evaluation of cognitive and behavioral outcomes as related to prenatal marijuana exposure. This study found verbal ability and memory was affected when the children were about 4 years of age, but they didn't find the same effects when the children were 2, 3, 5, or 6 years. So it's some question about what the meaning of that finding is. They did find increased behavioral and attentional problems when the children were tested at 10 years. This is somewhat similar to what Dr. Freed found. They found increased delinquent behavior in adolescence in those who had behavior problems at 10 years. And they found a few mild problems with coordination on an experimental task at 16 years. So they also believe that there are effects of marijuana which can be observed. It is important, I think, to note that for the most part, these are not the same effects that are seen from study to study. This raises questions about the nature of the samples and the meaning of these outcomes. Let's talk about opiates now. Opiates are a serious concern currently in this country. We know that opiates cross the placental barrier just as they cross the barrier from blood to the brain. So this means that opiates, when the mother ingests them, are reaching the infant. We do see growth reduction in women using opiates during pregnancy. Women who are using heroin, who are not maintained by a physician on a drug during pregnancy to control their opiate addiction, may have a problem obtaining the drug and therefore may have intermittent withdrawal from the drug. So repeated episodes of intoxication with the opiate and withdrawal from it, which is difficult for the woman and probably not very good for the baby. There is an increased instance of stillbirth among children of opiate users. Frequently, women who are pregnant will be placed on methadone maintenance. Methadone and buprenorphine are two drugs which are used during pregnancy as well as when the individual is not pregnant to reduce the difficulties associated with addiction to heroin and to illicit drugs. However, methadone maintenance can result in development of tolerance and dependence in the infant, which can result in neonatal abstinence syndrome. This is a syndrome of withdrawal that occurs as a result of exposure to any of the narcotics and to some other depressive drugs as well. The signs of neonatal abstinence syndrome are these, and they are very similar to those which are seen in adults who are suffering from withdrawal symptoms as well. Irritability, sleeplessness, diarrhea, depression, a number of aches and pains. I am told that this kind of this withdrawal is very much like having a very bad case of the flu. The infant often shows gastrointestinal problems, vomiting, diarrhea, stomach cramps, and has problem feeding. They may have increased heart rate, sweating. They show symptoms of central nervous system distress, including hypertonicity, which is a rigidity in their muscle tone, agitation, sleeplessness, increased tremors. They often have a very high-pitched cry, which is very unpleasant to listen to. They will have back arching, increased startles, and hyperactive reflexes. Some babies going through withdrawal show what's called excoriation. Because of their restless motion, they may show reddening of the fingertips, knees, and so on, where they're rubbing against the bed. And babies often will have problems with respiration as well. Neonatal abstinence syndrome has been a concern all over the country. And this is a map representing the rates in Georgia in 2016. The darker the color, the more frequent the NAS. And you will notice that there are certain areas of the state where there's a much higher rate than in others. The highest number of cases comes from the Atlanta area because the population is much greater in the Atlanta area than it is in the rural areas. But some of the highest rates, that's numbers per thousand, are occurring in the rural counties. I do think it's important to note that in Georgia, neonatal abstinence is diagnosed when there is a positive drug test, and that can include a positive test for stimulants like amphetamines and methamphetamines, as well as marijuana, cannabinoids, and opiates. And as you'll see, the most commonly identified drug were stimulants, followed by opiates and cannabinoids. What do we know about the developmental effects of heroin and methadone and other opiates on child outcomes? Well, there have not been extensive studies as yet on the long-term effects of the opiates in the most recent episode of opiate use, which is occurring now and occurred as a result of the increased prescription of opiates in the 1990s. Previous to that, there was an opiate epidemic that occurred in the 1970s in this country, and this occurred mostly in relation to heroin. At that time, Loretta Finnegan, Carol Kaltenbach and her colleagues, as well as Sidney Hans, Joe Marcus and his colleagues, carried out a number of studies looking at the effects on the infant of prenatal exposure. And I've listed some of these articles here. Hans and her colleagues found no differences in mental development at 4, 12, and 24 months of age when they compared opiate-exposed and non-exposed children. Kaltenbach and Finnegan found no differences in mental development scores at 6 months, 12 months, and 24 months when the two groups were compared. Another study done found that between 3 and 6 years, heroin-exposed children perform more poorly than their peers on a cognitive index in one study, but the same on behavioral and skills in another study. Most of these researchers concluded that developmental problems which were observed in children of women using opiates were probably the result of environmental factors rather than the direct effect of the drug. Now, what is the effect of stimulant drugs? Another frequently abused substance category is stimulant drugs, and that includes cocaine, methamphetamines, and other similar things. What we see in these drugs are growth retardation, which is to say that baby may be smaller than average. This may be related to the mother's nutritional deficiencies during this time. There does seem to be an increased risk of fetal wastage or loss of the pregnancy, which may include miscarriage and stillbirth. We see an increased incidence of preterm birth. And in this picture, you see a preterm infant who's may or may not have been exposed to stimulants. One of the things that's important to know is there is no such thing as withdrawal or NIS from cocaine or methamphetamines. They do not go through the kinds of highly unpleasant symptoms that we see in infants who are exposed to opiates. They're just more likely to be sleepy and have the negative effects of their preterm birth. When we look at the long-term effects of stimulants on development, it's a very complicated question, and the most thoroughly researched drug in this area is cocaine. Methamphetamine has a very similar structure and probably has similar effects. There has been research in that area as well. And what we believe is the following. We do not see any effects on growth following birth. So typically, these children may be a little smaller at birth, but there's a catch-up period, and then by the time they get to a year or two, they're similar size. There's no evidence of effects on intellectual ability. The only thing that has been regularly found is alterations in arousal regulation or response to stress. And this appears to be a persistent finding across a number of studies and over time. It is observable in early infancy, it is persistent through middle childhood, and we have identified this effect through imaging studies in adolescents. Now let's talk about the effects of alcohol exposure. Alcohol, which is a very common drug, unfortunately has significant effects on the child if the mother uses heavily. And the most significant and negative effect is what is called fetal alcohol syndrome, which includes deficits in growth, facial dysmorphology, deficits in cognition and behavior. There's also something called partial FAS, which includes deficits in cognition and face or growth. There is probably a condition that can be called alcohol-related neurodevelopmental disorder, which includes prenatal exposure and effects on behavior. And there's also a condition called neurodevelopmental disorder, prenatal alcohol exposure, which includes cognition, behavior, and deficits in adaptive function. And this NDPAE can occur in any individual who's exposed to alcohol. It is the behavioral component of the FAS and can also occur in those who are less severely affected. Taken together, these conditions are called fetal alcohol spectrum disorders. One of the important things to understand about FAS and FASD is that it lasts a lifetime. These are pictures of an individual that we've been following since before he was born and have seen at 2 years, 15 years, 25 years, and 37 years by now. And we have found over time that individuals who are alcohol affected have the potential to have deficits in cognitive function, in development and learning. They may have learning disabilities. We're also seeing problems with vascular and cardiac function, some problems with vision, physical facial features, motor dysfunction, and what's called microcephaly, or a small head. There are secondary disabilities associated with alcohol exposure, which include school failure, mental health problems like depression, failure in vocational function and legal problems, psychiatric diagnosis, and often substance abuse. How do we diagnose FAS? Well, we have to know that there's prenatal exposure, and then we look for facial features. And here is a picture of a child who has FAS and a cartoon illustrating the facial features associated with this disorder. Here we see that she has small palpebral fissures, which is the opening for her eye, a flattened philtrum or upper lip, and a thin upper vermilion, or the colored part of her lip. She also is small in size and has significant damage to her brain. Alcohol-related growth retardation is also an important issue, and this may affect weight, length, and head circumference, and it may be persistent or gradually resolve and is most evident in the neonatal period. Damage to the CNS, or central nervous system, is the basis for the behavioral effects of FASD. And we know that there can be a whole range of outcomes associated with the prenatal exposure and the damage to the central nervous system. And they can range from frank damage to the brain that can be observed in a neuroimaging. They can be milder effects. They can be something that produces learning problems or behavior disorders. And then in some children who are exposed, there are no effects. Children with FASD may have problems in the following areas throughout their lives: physical and motor, developmental and cognitive, behavior and social, and in academic functioning. And you'll see listed under these categories the kinds of examinations that need to be carried out to determine whether or not the individual has such a problem. For instance, for the physical, you need to do eye exams, you need to do a blood pressure. For developmental and cognitive, you have to assess the individual's ability. For behavior, you have to identify whether or not there are behavior problems. Another area that's frequently a concern when we're thinking about children who are prenatally exposed is this arousal regulation problem that's seen in cocaine and self-regulation. Self-regulation involves exerting control of your behavior and of your arousal in order to interact effectively with the world. And this is influenced by the individual's physiology and by environment. And we find that this is frequently a problem among those who are alcohol and drug affected. Thank you for your attention.